offer about a decade back. However, in the last 10 years, 8-10 years, many things have changed. It still remains a good standard of care for the non-adeno variant, for somebody where you cannot actually do the test. Sometimes the biopsy blocks are not adequate, and there are many other logistic issues. It remains by and large palliative. What chemotherapy has proved over the last 2 to 3 decades that is definitely better than giving only supportive care. We give them some relief of symptoms. We give them some benefit in number of patients living more than a year compared to only on supportive care. But the figures are not very dramatic, not very encouraging. What we have been used conventionally is a platinum doublet, either Prexate plus platinum or a taxane plus platinum, or at times a single agent platinum drug, or a combination of other agents which have taken a back seat in today's date, like minorelp. This is applied on the basis of various randomized control styles, huge meta-analysis, and very systemic reviews. So that definitely been standard of care. But then we have things which are promising, which we have discovered in the last decade or so. Chemo also will have a role in those who are responding as a maintenance therapy. A few patients will be eligible eventually to progress for second line of chemotherapy also. But not very encouraging figures and not with good quality of life at the same time. Briefly about chemotherapy in lung cancer, they are basically a unique class of medicines. They are antimetabolites, they are alkylating agents, they are DNA damaging agents. The sole funda of them is that they work in a very specific way and they finally cause what we call as cell kill. They are cytotoxic. But then, in my words, it is like AK-47. When it starts shooting, it kills the bad cells, yeah, but definitely it also gives some brunt to the good cells. Consequently, the diagram depicts the side effects, and we all agree that there is no particular body part which is largely spared. Ranging from hairball to taste issues to GI disorders or GI upsets. Sometimes long-standing patients can have cardiomyopathy. So it comes as a baggage full of side effects. This is what I feel we were maybe a couple of decades back in general, but more specifically for the lung cancer. Everybody trying to understand, but nobody individually able to give some dramatic outcomes. We are definitely getting better. Coming to the lung cancer part, what we have realized that we are able to not only understand, but we are able to interpret and implement which pathways go wrong and how we can tackle them. To be specific, we are better in understanding of the EGFR pathways. We are better in understanding the VEGF signaling. And of late, the last say 2 to 3 years, we have some dramatic responses or information and strong data to support use of immunotherapy, which I call in my words as the Brahmastra of oncotherapy as of now. If not for all, but definitely for those few who will definitely see probably 2 years or even more, at the same time being functionally active with good quality of life, which only was a dream when you were on chemotherapy. So briefly about these pathways, the first, which is the most old one now, I can say EGFR mutations. They are basically driver mutations. So what does that mean? That this is a protein on the cell surface which is behaving abnormally. It is having an activating mutation and the cells function much more. They are not able to be controlled by the normal working feedback loop inhibitions. So in a way, it is the USP of the cancer cell, but what we have realized that same USP can be made a limitation. So if you can target this mutation, our target therapies work like an Achilles heel. Cancer की दुखती रस को हम पकड़ सकते हैं. Only if we are able to offer some proper therapy. There are many in the pipeline. We have realized what is the mechanism, but interpretation and implementation is still not approved or validated completely. There are various studies from Western population, India, Asian population, where the range of these mutations all put together is quite encouraging. So probably 2 to 3 years down the line, I would say lung cancer of adenocarcinoma type, 50% or more would be eligible for target therapies directly, upfront, and not chemotherapy. To be more specific, they are these Jeftinib and Aglotinib. The first, they are like Tendulkar and Sehwag of this team. Then came the second generation, Afatinib and Dacomatinib. Then the most recent, which is in the armamentary and which has surprised all of us. Which way, by the way of data, we'll see that ahead. the third generation TKR of anti-EGFR therapy, osimertinib. Before we further go into our data and information which comes as an integral part of onco discussions, I would just like to highlight this graph which shows you that if you are on the drug which is on the lower curve, probably the grey color, and the drug of interest is the orange strip above. So these two curves, if they separate, it indicates that at particular point of time when the drug study is sort of planned, the more the curve separates, the more is the PFS benefit. What I mean is the progression-free survival is better. In simple words, it means that number of people will be with the disease, but they will be living in a better way. But disease control is definitely significant. So any drug which is on the orange curve, if the graph separates then the grey curve, only then it is accepted as the next standard of care. Stage 4 lung, we all know, we all accept that it is not really a curable disease, but the more the curve separates, it is going to turn that malignancy into something like a chronic disease. So probably eventually 10 years down the line, when I definitely have some more grey hair, we will be asking past history of diabetes, heart problems, kidney issues, liver problems, and some chronic cancer. And I will be very happy to accept chronic lung cancer as one of the medical issues. Going to the graph again, if you go towards the end of the study, so like this particular study was planned to be evaluated at the end of 2 years or 24 months. There we can see the two curves are already separated and they continue to do so. This is a very rare scenario in oncotherapies. Many drugs have been tried in phase 1, phase 2 studies. Many of them were encouraging in the earlier split of the curves, so PFS was there, but very few drugs were actually able to keep the separation at the end of the study. So any drug that has the curve separated is definitely better. So any drug in the orange curve, the curve separates at the end of the study time frame is definitely better than the old drug. So this orange drug will be accepted as new standard of care or something that should offer upfront as compared to the drug in the grey graph. So this is the importance of a PFS and the OS understanding. So the simple words, the better the curve separate, the earlier they separate, and the more they remain separate. It is only better for us as a new drug. Now, how do these anti-EGFR therapies work? As we said that there are 3 generations. The first generation, erlotinib, they are reversible binders. So eventually you will see them having a loss of response generally around a year. A good number of people will live healthily with these anti-EGFR therapies, but we tell them that probably starting off in Diwali this year, next Diwali around, probably we'll have to discuss about second line options. The second line options which were studied in trials and approved were afatinib and dacomatinib. How are they different? They don't block only the EGFR family, they also block the M.B.B.S family, which a subset of which is EGFR. Their binding is irreversible, so definitely they are more better in terms of responses, but what also we have learned with time that they come with a package of side effects which was not expected, especially after using the first line of therapies. However, they seem to be not working in the orange graph. Orange graph is where the mutations set in, because as we all know, the cancer cells are genetically smart. They are like if all of you might have seen the movie Species, the heroine in that movie changes her behavior, changes her the way she looks. So they are like, they'll be going to change. So this is possible with that orange thing where they have acquired mutations. That is where the second line of anti-EGFR therapy has taken a backseat. And for that, luckily we have many more drugs tried. What is approved as third line, and the most recent study, Flora study, has now stamped it that you do not go on from first line, second line to third line, but directly begin with third line. Why so? Because it is very mutation specific. Although it acts irreversibly as a second line, it also acts on this mutation. So somebody who has been on the first line of therapy before osimertinib was discovered, has crossed an year, has this progression. We were like probably 6 months back talking of chemotherapy. Today I will be talking about no further chemotherapy. We'll probably give you second line and third line of anti-EGFR therapies. So this evolution continues. We have many more pathways and many more drugs that are being studied. But as of now, for the anti-EGFR therapy, these 3 lines are only approved, and we are using it right left with very wonderful results. Briefly about the study and the trial which gave approval to Jeftinib, the forerunner of all the anti-EGFR therapies, the generation 1 molecule. It was the IPA study. What was studied in simple words is locally advanced or metastatic lung cancer. They preferred people who were not smokers. This was used upfront, so they were like chemo naive. And fitness wise, PS1 to PS2, so they were like up and above and individually doing their course. What studied was Jeftinib, the first generation anti-EGFR TKI versus the current standard of care. They had used a Trexate and a platinum combination. So again, here we see the curves. The green color is the drug of interest and blue or grey color is the drug or the standard of care chemotherapy doublet. We see here that the curves do separate at the point of study. So these points where the drug is evaluated is set by the basis of statistics. So that there cannot be argument over it. It depends upon what type of study is planned, what is the number of patients that will be analyzed, and this is generally accepted unanimously all over the world. So here we see that at the point of study of around 12 months, there was definite benefit in the PFS. So number of patients living with the disease in good control was definitely better than chemotherapy. What further probably made us wiser is the separation of the two patient subset as per on the basis of having a EGFR mutation and not having an EGFR mutation. We have to keep in mind that this study was done at the point of time when EGFR was more of a hypothesis. It was not really proved with robust data, but then there was a learning graph. So it worked definitely better in the EGFR positive subset. However, when we reached to a study endpoint, number of patients living quite okay without the disease or with disease control rather was now not dramatically separate. So there was no survival benefit, but still accepted as the standard of care because the quality of life was much better, oral tablets, so no admissions, and people who were eligible were extremely happy. Second generation, the third generation, again there were standard trials done, optimal trial, the Ensure study and the Eurotech trial, which gave a very clear approval to the second molecule, Erlotinib. Afatinib was the first drug in the second generation of TKIs. We have Lux Lung 3 and Lux Lung 6 studies, which again accepted them as a, an optional standard of care. And important aspect of the Lux Lung studies was that here Afatinib actually gave OS survival benefit. The number of patients who were living with disease control was definitely better. Again, for not all exon mutations, but specifically for exon 19 mutations. So if in an OPD I have a patient, say 48-year-old female, non-smoker, adenocarcinoma, we ask for the EGFR panel and she comes with an exon 19 mutation, I have almost 4 to 5 drugs to offer. If the fitness permits me, logistics are manageable, I would definitely consider Afatinib. Briefly about the studies, again as we had just discussed, the curves did separate in the point of study where PFS was analyzed. However, again, as in the first generation TKIs, second generation TKIs too didn't show a dramatic difference in the OS in all the types of EGFR mutation, except for the exon 19 one. So we still had some more things to discover. Then came the study of Dacomatinib, which is the second generation TKI. Again, as we all will agree by this time that the curves did separate, there was a PFS benefit. What was slightly more pleasing to us was the Indian and the subcontinent, the Asian continent that we say, the responses were more pronounced than the Western populations. So the Asian patients, which includes India as well, definitely was slightly lucky to have adenosine than the Western suburb populations. Again, second generation TKI, Dacomatinib, however, eventually didn't show up OS benefit. So we were happy but not excited. Tolerance was a concern with second line, as we earlier mentioned that the binding was irreversible. So we expected far more better benefits. Sadly, benefits were not dramatic, but it definitely come with a baggage of side effects which were disturbing. Quality of life improvement was in the backseat, and a good number of patients actually had to stop the drug. So the excitement suddenly took a bad turn, and Dacomatinib practically is out of use. So the tolerance issues. Then came the most fascinating and encouraging study, the FLORA study, where the current standard of care then first generation TKIs, Jeffery and Erlotinib were tested with osimertinib, reversible binder, which will also act in the D790M mutation. What was also included for the first time was people with CNS metastasis. By and large, till then, CNS metastasis in lung cancer was like a big nail in the coffin. We were like looking at it, and the whole focus was only on palliative care, probably some radiation therapy, chemotherapy. At that point of time, we probably would have started discussion about supportive care only. However, with this thing included, we are expecting that even this subset of patients, which I would say are 5-10% or more, where we just had a full stop, the fact that they came with an MRI after headache with brain metastasis, they had something new to offer, something fascinating to see. As expected, being a better, potent and a stronger anti-EGFR, the PFS curve did improve. That is basically the waterfall plot which shows you quantification. And if we see across all the types of patients, what I mean is irrespective of the age, irrespective of the sex, irrespective of being Asian or the Western or the European, in spite of having some difficult sites, serious metastasis, they all showed consistent benefit. So it did stand by its name, being a better and a better potent anti-EGFR therapy. Yeah. FLORA study further continued, shows difference. As we just mentioned, in the difficult subset, the smokers and the CNS metastasis, it continued to show its good performance. Side effect profile was not very dramatically discouraging. So very peaceful drug. What if the patients were on anti-EGFR and they had progressed? We know again there are mutations.